I go from here? What do I do next?
Don't just take no-dos? Is that
Now,
what you're saying?
Yeah,
some
usually
don't turn
in
to the
experts have
no-dos.
said that if
food.
you've got
Yeah.
elevated
Yeah. No, that's
C4A,
not nearly as satisfying for
then that
me,
indicates
sipping on-
chronic
I don't generally sip on
mycotoxin
no-dos.
toxicity.
But you're gonna love
Maybe,
this, but
maybe
there's a-
not.
there's a
I've
company that
really
makes
tried to track down that literature,
caffeine,
and I
pterostilbene,
haven't been able to find
cobalt
very good confirmation. It's only really
Nice.
coming from a few
There-
sources.
It's like a time
I found out about
caffeine
this a
that,
number of years ago from a
I
patient
like
who
them.
came into my office
that
with
right?
chronic
You do?
I like
fatigue
them. I like
I
them.
like
and
them.
several other
Yeah.
problems.
All right,
She
Let's
had
go past caffeine
respiratory
to
allergies,
another,
pretty bad. She had
subject that will
chronic
have no
inflammatory
controversy associated with
proctitis.
it. That's the
And
carnivore diet.
she had what
So
had been
the question,
diagnosed as
carnivore
chronic
diet is
mycotoxin
extremely
exposure
effective in stopping
due to
autoimmune
excessive mold
disease
in her
despite
house.
higher academic
So
acid
we
saturated
followed these
fat.
markers over time,
Can
and
you
sure enough,
comment,
her C4A was
and
really
so I'll
high,
turn-
more
we'll
than
do a round
double
robin on this. I'll
normal.
turn it to Helen
Okay,
first.
and I tend to
she and
not
I
think
had
this was a
little
specimen
conversation about
handling
that in
problem
the
because the
green
numbers
room.
were so consistent over time.
Yeah.
She also had a
hopefully.
high
Where
TGF
do you
beta
start with this one?
and a high matrix
Number one, I
metalloproteinase
mean,
9.
yes. Once you
Some
take
have
out
said, well,
any
this is
potential
pure,
food
this is
antigen,
clear
so if you
evidence
eat
of
only meat,
mycotoxicity.
you
I
are
would
taking
respond to
out
that
a
and
lot
say,
of
this is
potential
clear
antigenic
evidence of
foods, so
immune
that can be
activation.
a great way
And
to eliminate
the
the
immune system is
triggers for
trying to turn
autoimmune
that
diseases.
off by cranking out the
problem I
TGF
see
beta.
with something like the
So
carnivore
something is
diet
clearly
is
going on.
the
Part of your
long-term
hypothesis might be
sustainability of it, right? Where
mycotoxicity,
are
but
all
don't
of the
stop there. If there's
phytonutrients that
anything we
we
can
know?
teach
I mean, we
you
have
this
years
weekend
and years of
is
research
to
to
not
show the
always
importance
go
of
to
all
a
of
single
those
diagnosis, but
plant-derived
to think about
nutrients
the whole matrix
for
and
overall
all the
health.
different possibilities.
And I'd love to see, I
So
think
I've
we
already alluded to
definitely
this.
need more studies on this.
When would you
What
order
what
this?
are
This
the
is a
long-term
third
effects of a
tier
carnivore
of
diet?
testing.
Clearly,
This is
you know,
when other
everyone's gonna be
markers,
different as
CRP
well.
said
We
rate,
all have different
are
ethnic
negative,
backgrounds that grew up,
but you're
you know,
still
or evolved
suspecting
with
some kind of
different types of
infection like
diet. You know,
Lyme
you look at
disease
the
or
Inuit,
inflammation.
they
Or
ate
if you think
mostly
this
a
person has
carnivore
got
diet,
mast
right?
cell
There was no
activation
access to those types
going
of
on.
other
Talked
vegetables,
about that
but there
earlier.
are specific
Multiple
populations. So I think
sclerosis,
it's
there's data
definitely
showing that
individual. I
C4A
would
can
love
go
to
up with
see the
MS, so
long-term
I find
research
that a
on it.
useful
What
marker
are,
there.
if you follow a carnivore
What
diet
about an
for
invasive
10,
fungal
20
infection?
years,
No,
what
I'm not talking
actually
about
happens?
mycotoxicity
What's the
exposure. I'm
effect it
talking
has on
about
your microbiome? I think
invasive
that's a really
fungi. Yes,
big unanswered
absolutely.
question.
Both
So I think
of these
there's
markers
a
can
lot
go
we
up.
still need to
Lyme
learn. I know
disease, we've
there's
talked about, and
definitely
Dr.
a lot
Schultz
of
will come back to
proponents out
that,
there that
and
feel good,
autoimmune disease.
and I can understand how you can have
Can't
a short-term
overstress
effect
how
of
important it is
a
to
beneficial, you know, you feel good,
collect
but
and
and it
handle
works
the
in
sample
autoimmunity by taking
properly.
away those antigens.
So
But
it's
long
got to be a
term,
good phlebotomist,
we
and
have
you
to
probably
look
should
at
alert
we
the
have to look at
phlebotomist
those things.
the patient is coming in to have
Karen,
this
any,
done.
any
Wants to-
specific,
All right, we're
So
whipping
short-
through this
Go ahead.
information.
My
Time
two
for a
thoughts to
very
just add to
short
Helen's
break.
are, yes, the potential to feel
Stand
great
up,
because
stretch,
of the low exposure
and
to
take
antigens,
a couple of deep
and
breaths.
it's going to drop blood sugar like a stone. So it's going to turn off inflammation rapidly. And for a lot of folks, despite the high protein, it'll put you into ketosis. So you'll get that energy boost. So in the short term, I just want to underscore that, just as Helen was talking about today in her now and also in her talk. It could be, you know, it could be an important intervention. I mean, it's interesting. They're studying the ketogenic diet in COVID patients. I think it was at Johns Hopkins, if I'm not mistaken. I'd have to look at clinical trials again. But I mean, I think short term as a prescriptive diet.
Well, I hope you found that relaxing.
Brings
Brings back fond memories of what it's like in Colorado in the summer,
what people are eating
which
in
was
blue
quite
zones,
some
where
time
they're
ago,
living,
but
you know,
the
long and
summer will
healthy.
come back.
You're not seeing those
Now, for the final
proteins to that
section of this
extent.
presentation,
Exactly.
I want to talk about cytokines.
When you look at
Because of the
longevity
pandemic,
studies,
because of COVID, suddenly
the blue zone
everybody is
people around
tuned
the
in
world,
to
are any of those
cytokines.
people
This is one of those
full-time
scenarios where I
carnivores?
used to
Like,
talk about
you know what?
measuring
They're
cytokines,
not a blue
and
zone.
people would say,
Well,
that's
they're
so
not a blue zone
esoteric.
community either,
Why
are
would you
they?
go there? Suddenly, everybody wants to
I
know,
know.
We were
can you
looking-
measure
we were looking at
cytokines
lectins,
during
right? In those
When
blue
acute
zones.
COVID
the blue
or
zones
during
eat a lot of
long-haul
lectins.
A lot of
COVID
lectins.
Yeah, it's
syndrome? And there's
Mediterranean
actually
style
research that
diet. Yeah.
cytokines do go up with long-haul COVID.
So speaking about
So
lectins,
what are the cytokines?
Dr. Fitzgerald will be
Proteins made by
talking about
immune
those
cells,
tomorrow. We
small
do have
soluble proteins,
an
interferons,
FA,
interleukins,
FAQ
tumor
on that
necrosis
as well,
factor,
so you might want to look that
factors,
up in
and
either
transforming growth
Let's
factors.
go
So there's
back to
a lot
the
of them, a
omega,
lot of different families.
prescription.
This is a
Number
long
of
list that you
questions
can come
on,
back and look at
dosage
later,
recommendations
but
for
we
young
used to
children
divide
with
them
inflammatory
into
disease. Kara, do
fairly
you
discrete
have a
classes. Well, this
particular,
is a T upper one set
model
of
that you
cytokines.
use, and
This the T helper 2.
Well, it
Then that
depends on the
started to
condition, and
expand
obviously it
T helper
depends on the
17.
age of the
Now we know that
child.
there's quite a few
We can
subclasses
for
of T helper
school-age
cells.
kids. I
What I
working
use
with
a
kids
graph
on
or
the
diagram
autistic
like this
spectrum,
for
we can
is
go
when I
quite
do
high.
cytokine
I mean,
testing
really
and I see
close
certain
to
ones that
what
are
we might
elevated,
look
I
at
will
in
come back
adults. So,
and I will
you know,
look at the
anywhere,
pattern.
maybe we would start a
And I
little
will
bit lower,
say,
500.
okay,
but
TGF beta, that's
could
elevated.
comfortably
That
go up
means
to a
something
few grams
is
a day or
stimulating
more.
T
And
regulatory
I think
cells.
that
Something is
there's a
trying to get
place
the
for
T
that
regulatory cells going.
when you're really
Or
trying to
I
turn
might
the
see
volume down
interleukin
on
8
inflammation.
up. And I would say,
Remembering,
well,
though,
why is
that
interleukin
they're
8 up? And I would try to
polyunsaturated
find
fatty
a graph
acids.
that says, in
You
this
want to make sure
specific
that there's some
patient, it's,
antioxidants
oh, here
in
it
there
is,
somewhere. So
pro-inflammatory. You see it in
the diet
autoimmune
should be
disease.
reasonably
I've
healthy. There
seen
should
it
be some
in
antioxidant
inflammatory bowel
sources
disease.
in the diet.
So when do you
You
order
may need to
cytokine
lean on
testing?
supplements
Again,
as
this is
well.
not your first round of
But when
tests.
you go higher
Okay,
dose in,
this is
in
when you've
anyone,
already
but
done the basic
especially
testing,
in kids,
CBC,
you
SUD
want to
rate,
be thinking about
ESR,
taking care
maybe
of
complement
those
levels,
fatty
and you're
acids.
still drawing up a blank, but you
we can
think there's
comfortably go really
inflammation
quite
going
high
on.
in
Person's
peds.
got inflamed joints, morning stiffness, achy stiffness.
And I
So
just
So
want to
that's when I'm
reiterate,
going to measure
Terry,
cytokines.
just,
I
the
rarely
role of the
order
omega-3 fatty acids in
any
the
of them by
microbiome.
themselves.
You know, we're
Occasionally
talking a lot
interleukin
about the
6,
importance
but
in
I
the cell
think that
membrane, and that's
CRP is a
obviously the
pretty
most
good
critical
substitute
thing,
for
but
that for most
the
scenarios.
study that I presented,
But if you want to look at the
where
whole
you
pattern,
actually
you
can
get interleukin
transfer
6,
a lot of the
interleukin
effects of the
17, TNF
omega-3 fatty
alpha,
acids with
TGF
a
beta.
microbiome
It's
transplant.
the
So I think there's a
profile.
lot more
It's
that
the
we still need to
pattern.
learn.
That's
You
what
know,
you're looking for. And I'm
there's
not
a
expecting you to
really neat study
memorize
looking
the
at
pattern.
the maturation of
I'm
the immune
expecting you
system in
to
infants
recognize that
with
something
fish
is
oil
going on
and
when you
Mhm.
see a
balancing
number of
between
elevations.
TH1 and TH2. So, pregnancy is
Interleukin
sort of a
6,
TH2,
just to
if
point
you will,
out, does
dominant
have some
condition.
literature on measuring it.
Early
It's elevated
infancy
with
and
cancer, rheumatoid
childhood is when
arthritis,
the immune system
body
grows
fat,
up
type
and,
2 diabetes, right?
establishes
These are all
tolerance,
the
et
things
cetera,
that
and
where you see
TH1 and the
C-reactive
rest of the
protein going
immune
up as
system
well,
components really kind of
atherosclerosis, heart
grow in
disease.
quantity.
So
And
you can pretty
interesting
much
research
substitute
on fish oil
CRP with
actually
IL-6 for
helping with
all
that
of these
balance.
things.
Mhm.
Terry, excuse me
Here's
if I
a
missed
really
hearing you talk
interesting
about this, but
study
we know
that
that
looked
the
at people
infant
that
brain,
engaged in
takes in a lot
ultra
of
distance foot
DHA.
racing, a
Yeah.
Spartathlon.
DHA,
So you would think
especially for
these
pregnant
must be some of the
women,
healthiest people on
and
the
then,
planet. They go out and
Yep.
run 50
for,
miles
like breastfeeding women,
or
et cetera,
longer.
that
They
we
run
just
100
wanna
miles,
put in
right?
tons of
Is this a good
DHA,
thing?
like there's
Yep.
Well,
one
in
of
this
the scenarios
particular
where we
study,
know that
they
Yeah.
measured inflammatory markers
weighs
afterwards,
out
and they
better
found
than
their
EPA.
IL-6 went up,
Is
CRP
there,
went
do we
up,
know
serum
at
amyloid
what
A,
point does
DNA went up.
higher
Free
requirement for
plasma DNA
DHA
went up, and they had more
stops being so
peripheral tissue
significant?
damage.
That's a
So
good
what they
question.
were saying is these
In terms of
Year of
development,
Spartathlons,
age or
the
two,
ultra
or
distant foot
well,
races,
the
were
brain,
resulting in a potent systemic
the
inflammatory
dominant
response.
omega-3 in the central nervous
I know
system
people
is
that do
DHA.
that. I
So
live in
I
Boulder,
think just
Colorado,
along the
so
continuum
there are
of life,
people
if you're looking at
in
neurodegenerative
my circle
conditions, I know
that
somebody
engage in this,
was
that
asking
love it,
about
that feel good
Parkinson,
when they
you're
do it.
still
My
leaning
suggestion
heavily into
is
DHA.
maybe measure some of these
EPA
markers
should be
in
there
them
as well, but
to see what's going
EPA
on, and
can
consider
convert to DHA.
using
But you're
things
leaning,
to
I think,
quell
depending
that
on the
inflammation
indication, you're
like
leaning in it.
curcumin, which
I
we
don't know
talk
the
about
answer
a
though,
lot
Bob, to your specific
in
question. But I
this
do want to
module.
circle back because as we were talking about
Here's an
arachidonic
interesting
acid
paper.
earlier, and that's that's an
Individuals with
important player in
intermittent
development as
explosive
well.
disorder and
So you
aggression
don't want to
have
disappear
higher
it
levels of
entirely,
interleukin
but it's
6
going to
and
be
CRP.
hard to disappear
What's going
arachidonic
on?
acid. I mean, we
Are
make it
they
readily, and
but
yeah.
having these
arachidonic
high
acid,
levels
isn't that
because
in
they're
most infant
aggressive, or is it
formulas?
the other way around?
Yep, it sure is.
It really makes you wonder about the
Okay,
mind-body connection
let's
here.
talk about
So if you're a
Bob,
psychiatrist, you might
when you
consider
talked about
measuring cytokines in your
bowel
patient
rest
or
and
C-reactive
medical foods.
protein
There were a
in your
lot of
patient.
various comments
Here's
about
one
that. So
specific
what I'd
scenario
like
where
to
an
do
individual
is
cytokine
have
might be
there
worthwhile.
are a number
Okay,
of
there's a common treatment for
nutritional supplement
MS,
companies
multiple
in
sclerosis,
the virtual exhibit hall
interferon
that,
beta.
many of them
In a
have
mouse
medical
model of
foods. If they're
inducing
in the virtual exhibit
multiple
hall,
sclerosis, there are
we
two
have
forms of
vetted
disease.
them. We think
One
they
is
are
driven by
very
the T helper 1
accomplished
lymphocytes,
companies. Having
and the
said
other one's
that,
driven by
why
the
don't we just go around the
TH17
horn
lymphocyte.
and ask each of
It's
you
been
what
shown
medical
that
foods do you
if
use,
people with
in
relapsing
general?
remitting
So just,
MS
why don't we start with you,
have a
Bob,
high
because that's
level
where
of
the question
interleukin
came up.
17, they don't
Well,
respond as
I'm
well to
fond of
interferon
the
beta.
thorn medically.
In fact, they
And there's
tend to
one in
have
particular that's
worse
got
disease.
SGS in it, which is
They
the
need more steroids and
glucosinolate. So
more
that's
drugs,
particularly
more of
helpful for
a whole
upregulating
range of
phase 2.
medications. And the
So
conclusion
I
of
like
this
to use
paper is that
algorithm. It also
interferon
tastes
beta
pretty good.
may be pro-inflammatory in
I'm
people with
open to
MS who have high
other
levels of
companies.
interleukin
I'm not,
17. So
like,
it makes a
It's not the
pretty
only one
good
I use.
case for
I've been-
measuring
I've got
interleukin
more experience with
17
Medicare.
as a single cytokine
How about you,
in your
Helen?
patients.
Do you use medical foods? And if
Here's
you do,
another
which ones
paper
do
that
you
I thought
use?
was
Yeah,
really
taste is always an
interesting,
issue with medical foods.
that
Yeah,
Usually
you're gonna
you
eat
get
it for 3 days.
numerous
Yeah,
cytokines are
exactly.
involved
You
in
can get them to take
rheumatoid
you for about a
arthritis
week, and then
pathology
they're
and
really
could be
tired of the
biomarkers.
taste. But
What about
I
the
often go
scenario of
to the
undifferentiated
ultrasonics,
arthritis? These
Fluorogenics,
people with
that's one of
very
mine.
early on
For
that have a
really
normal
good gut
rheumatoid
feeling,
factor,
I like the
they have a
GI
normal
Revive
CCP,
from
their SED
Designs
rate's
for Health.
fine,
I like
their
the
C-reactive protein is fine.
N-acetylglycosamine in it. It's
You
got
really
really
can't figure out
high
what's
amounts
going
of
on, but
that,
you
which has
see
been
their
shown
joints are
to
swollen or
actually
they
heal
have significant
inflammatory
morning
bowel disease in
sickness.
kids. There was a good study
Maybe
on
you
that
need
one.
to consider
So
getting
those
a
are sort of
cytokine
two of
panel.
mine. I
And
often
there's
add in,
evidence for this.
SBI
Okay, this is a paper out of
I really
Sweden.
like that when you're
Upregulation of
dealing with
cytokines and
dysbiosis,
chemokines
and I'll talk more about that
predates
when I
onset
talk
of
about
rheumatoid arthritis.
dysbiosis. So
Now,
those are
I
some
think
of
there's a
my
little
go-tos.
fallacy in this title.
Yeah, actually,
Predates the
yeah,
onset.
I did.
Well, no, I
would
don't
add,
think so.
you
From
know,
the
using a lot
functional
of
medicine
SBI Protect
perspective,
here, I do
it
think
didn't predate the onset. The
the
loss of tolerance
the
is the
Designs for Health
condition.
product is good, and we do
The
use
chronic
we use
inflammation
quite a
is
bit
the
of
condition.
Zymogen
So the
as well.
upregulation of cytokines was simply
We use
early
I like
on
integrative therapeutics
in
elemental diet. I know that's
the
like divergent
scenario,
from this,
right?
but
It's not an
yeah,
on-off
we use
thing. They
we use
didn't
that
have
quite a bit as
rheumatoid
well.
arthritis. Now they
I
do
will
have it.
second that one for
They've
CIFM.
always had whatever they had. And
Yeah,
the
different
cytokines
medical
and the
foods,
chemokines were
obviously,
the
for different,
earliest indicator. So
indications.
what they did
So
in
I
this
think
study in
we've
northern
given you
Sweden,
a
they took
broad
blood samples from the
spectrum,
general
and I encourage
population,
you to
froze
go
them,
into
and then they
the
followed these
virtual
people
exhibit
over a
hall. We
number of
also
years.
have a
If
practice
people in the
implementation
study
sheets
developed
that
RA, they
kind
went
of
back and
lines
looked at
up,
their blood samples.
different
And
products,
sure
so
enough,
you
a
can
significant
see,
number
as
of
opposed to
people
going to each
had
of the different
elevations in their
companies, you can
cytokines
see
years
products lined up
before
so
they
that
even
you
had
can compare
symptoms,
and contrast of what's
even
in
before they had
similar
obvious joint
products for
disease.
similar
So
conditions,
that
and you
loss
can
of
make some
tolerance was happening
choices in that
early
way.
on,
Um,
early on. And
okay,
what are the
so
ones that
let's
they
just a
found
couple more
elevated?
questions
Interleukin
before
1
we
beta,
wrap up.
IL-2,
What
IL-4,
are your
IL-6, TNF
thoughts
alpha,
on
interferon gamma, MCP1, and
on
MIP1
increased
alpha.
endogenous glutathione
Interestingly,
production with nutritional
IL-17
methods
tended
like
to
cold
flare,
thermogenesis, high
tended to go
intensity
way up
exercise,
right
etc.?
before
I
the
know we're not
person
going to cover that, but
developed
it's an
symptoms
interesting
and then
question.
drop.
Bob,
So
do
it
you
must
have
be
any
playing some
experience
kind of
with
role in induction.
increasing glutathione with those two particular
This is
therapeutic
an example of how to use
interventions?
this. This is a patient of mine,
Well,
38-year-old white female. This
I'm
woman
familiar with the interventions.
miserable.
I mean, like, I
She had
recommend the Wim Hof
chronic
method to
severe
people.
fatigue.
I couldn't say
She
that I
had
practiced the
diffuse
Wim Hof
pain that had been called
method. That's
fibromyalgia for
something I would
want of a
reserve
better
for
term.
Canadians.
She had been diagnosed with Lyme disease and
Some
she had
Canadians
fuzzy
don't like
brain,
it.
organic
Yeah.
brain syndrome as a
It's,
result of
I
the
mean, the
Lyme,
whole,
with
the whole
poor
idea of
memory, poor
hormesis is
tracking,
a really
etc.
valuable one.
And she had
I'm
chronic
not sure there's
abdominal
a
pain
lot
with
of data
pretty severe
on
dysbiosis
these, hormetic
based on a
stressors
stool
like
analysis
cold
that I did on her.
or HIT.
So we were looking for markers
Actually
that might help
raising
confirm what's
glutathione
going on.
levels. If you
Frankly,
did
she was
raise
getting a
your
lot of
levels,
pushback
it
from
might
her
be because
insurance
you're
company
causing
that said,
inflammation
"Oh, this is all made
and you're
up. You
getting
don't have
an
anything wrong
acute
with you
phase response.
at all."
You
And we
know,
were
there's
looking
what
for
that
markers
would
that would
mean.
confirm something was
there's
happening.
there's
So I did a
interesting
cytokine
research
panel
that
on her.
you guys are familiar
And
with, and
look at what we found. She's got elevations in a whole
post-exertional
range of
oxidative stress
cytokines.
with
This
antioxidants,
indicates to
inducing
me
insulin resistance,
that she has
and
a
wreaking
diffuse
all sorts of
immune
inflammatory
activation.
mischief.
So a
So that
very
would
useful
suggest
test
that
to do
we're
in
turning
this
on the
particular
exogenous or the
scenario.
endogenous
Yeah.
system.
It
and
wasn't
we wanna
just
just let it do
TH1,
its
it
thing.
wasn't just TH2,
But as
it
far
was
as actually
all of the
measuring
above,
increased
diffuse
glutathione in
immune
circulation, that makes
activation.
less sense
So
because
I've
we'd
got
be
to go
using
after this scenario with
to
a
quench the
really
post-exertional
comprehensive
oxidative
anti-inflammatory
stress.
regimen.
Mhm.
Now, coming down
Yeah,
to the
no, I think
last few markers that we
Post-exertional
look at,
oxidative stress,
one of my
thank you.
favorites is
I
natural
mean,
killer
that's where you
cells.
get,
Yeah.
Here we see a
yeah,
picture of a
I mean,
cancer
otherwise
cell
glutathione-
that's being
Yeah.
attacked
You
by
want it to
natural
do
killer
its
cells.
thing. Yeah, you don't want to
Exactly.
turn it off.
I like
but the
that.
person was
I want
inquiring
this
as to whether you
happening
could
in
actually
me right
measure
now.
it
I
in
want my
circulation,
natural
and
killer cells
I think
to
it's happening
be
intracellular.
surveying
You
any
know, killing the
mutated
mitochondria.
cells in my system, recognizing that something is different about them and attacking them. The little things sticking out of the natural killer cells are a little proboscis. They're sending out, little extensions of themselves that latch onto the cancer cell and release granzymes and other enzymes that will basically destroy the cancer cell. when you do a
just give
CBC,
a
up to 20%
differential
of
in
the
terms of how you
lymphocytes
would use
that you're measuring on the
flaxseed
CBC
why
are
you
natural
use
killer
it
cells.
for
They're a big part of
perhaps,
the innate immune
not
system.
only the
And their
ALA,
job
but
is to
the lignans and
recognize cells
malignans,
that are either
and maybe
injured,
you're using that
infected by
specifically, 'cause I think
viruses,
you,
for
from
example,
a
herpes viruses,
ALA
or
standpoint,
tumor
you
cells
have
that
to
have
use a heck of a
transformed.
lot of
When they
flaxseed.
transform, they don't display major
Yeah.
histocompatibility
Well,
complex class
I know if
1.
you're
So
leaning
they
on
lose the marker that
if
says,
you're
I'm
if
in,
you're
I'm
treating
part of
somebody
this
who's
scenario.
vegetarian,
You know, I'm not a stranger.
yeah, you
I'm
need
part
to
of
go
the
with some oil
the
as well,
family.
and you need to
When
go with some
natural killer
algae
cells
to
see
get
that, they
to
should
get
go
the
after them.
downstream, EPA
And
and
when
DHA.
they recognize these
because
cells
it's true,
infected
you
by
need to,
viruses, and that includes
you need
COVID,
to do quite a bit to,
natural killer cells,
and then you have to follow up
adequate
with
natural killer
measuring.
cells
So,
play an important role
there's
in
absorption
helping surveil
variability,
against
there's
COVID.
conversion
When
variability.
they
So
see these
if you're
infected cells,
using it
they inject perforin
to
granzymes,
achieve
which are
some of
proteases and other enzymes
the
that basically
downstream
cause
omega-3 fatty acids, you just have to really
cytotoxic
pay
injury, make the
attention.
cells
If you're using
implode.
it to inhibit
What
delta
activates
60
natural killer cells?
saturase and
Cytokines,
control the
antibodies,
omega-6s, you
certain
don't need to
ligands,
be
certain
using
stressors,
as
etc.
much. And
Natural killer cells are regulatory. They interact with a
what
number
else?
of other immune
Yeah,
cells,
I recommend using
especially T
flaxseed if you can
cells,
grind it
dendritic
fresh.
cells,
If
etc.
you're good
So
about that,
they're
that's the best way.
really
That's the way that you're going to get the
central
most
to the whole
nutrient bang
innate
for your
immune
buck is
response.
just to grind it
How do
fresh
we measure
daily.
them?
And,
In
if you
functional
can take up
activity.
to a quarter cup, that
Okay?
would be
Not
you
you don't want to
fabulous
just
daily
measure
protocol.
whether they're
Yeah, and
there
there's
or
a lot
not.
of fiber
It
in
doesn't tell you how
flaxseed,
active they
right?
are.
So
You
it's
want
a
to
great
measure
way to increase
natural
fiber
killer
as well.
cell
I'm
cytotoxic
also a fan
activity.
of
That's
chia
what you
seeds.
write on
Yeah, they
the
taste
lab
good. Yeah.
requisition.
They may have more
And
omegas
I
in them.
do tell patients when I do
There
this, and
was
I
that one
measure
paper
NK
that
cells a
showed that
lot,
they were
is notify the
converted
lab that you're
efficiently,
coming in to get this drawn so
or
that
very
the lab
efficiently,
will
actually.
do the right test.
I don't know that there's
Otherwise,
been anything else
they
beyond
sometimes
that,
will
but
screw up
it's up to you.
and
You just need,
not
if you're
measure
going to use
lytic
them
units. They will
to
only measure
achieve
the percentage
EPA,
that's there.
increased EPA and
Where
DHA
do you
levels,
see a
you have to
decrease
test.
in
I don't think
natural
there's any
killer
way
cells?
around it,
A lot
really.
of scenarios.
I think that's
Cancer
a really good
or
point,
cancer chemotherapy.
There's
So having
different,
cancer makes it go
differential
down.
conversion, and as I say,
But
you have to
cancer
use a lot of
chemotherapy
flaxseed, you
knocks
have
out
to use a lot of
NK
flax
cells.
oil.
And that's
even
one
if
of the
you
scenarios
do,
where I
I'm not
measure
sure if you
them
get
the
there,
most
certainly,
in people that have
Yeah.
gotten
getting
chemotherapy.
to, taking
And
EPA,
I want to
DHA,
know,
either vegetarian
should I
or
institute a particular
fish sources is a
immunomodulator
better
therapy,
way
which I'll
to
talk about
get there, but
tomorrow.
there's so much
People with chronic herpes
nutritional
often
value,
have
other nutritional value
low
in
NK,
flax seeds.
and there's
So
things you
I
can
think
do
it's a
about
great-
that, like
it's a great
vitamin C.
smoothie,
I
or
know.
chia seeds.
Chronic
It's a
fatigue
great
syndrome
in a smoothie.
often
you like
can
using
result
things
in
like
low
walnuts?
NK activity. Again,
Yeah.
telling you something's
Yeah,
going
for
on
sure.
another way
with
Absolutely.
the immune
Yeah.
system.
Yeah, so
Any kind of
somebody was talking
inflammation,
about sea
if it's
buckthorn, and,
chronic, can decrease NK. Lots of autoimmune diseases can
it
decrease
has a
NK.
pretty reasonable amount
Obesity,
of
cigarette smoking,
alpha-linolenic, so
chronic
that's a
stress, and
possibility.
too much
It might not be
icosapentaenoic
practical in
acid.
the long term,
Just
but
pointing
I
out
think chia,
that
you'll get
fish
more bang
oil,
for your
omega-3
buck.
fatty
Flax,
acid,
you will,
is
especially for the
immunosuppressive.
cost.
I'm not necessarily saying that's a bad thing,
All
but
right,
it's
well,
something
with
that you've
that,
got to
we're
keep in
going
mind.
to
If you're checking
close up
NK
this
and it's
Q&A
low,
for the evening.
then
Thank you,
did you
Kara,
just start
Bob,
that
and
person on
Helen.
fish oil
And I just
recently?
have a few closing comments.
Maybe you need to hold the fish oil for a little while, recheck the NK, and see if that's making a difference. So when do I measure this?
The first thing
monitoring people
is,
after chemotherapy for cancer. If I'm going to use immunomodulators in them, say a person's got recurrent infections, especially viral infections, can sometimes be useful with thyroiditis and in chronic fatigue syndrome. That's a scenario where I do measure it a fair amount.
I hear from clinicians saying that
Here's
they're
an
too
example
expensive
of
for
something that
patients,
might surprise you a
so
little
it's hard
bit.
to get them from an
Well, you're not going to be
economic
surprised by
standpoint
this first
to do
statement.
that.
We get fatter when we get
I
older.
disagree.
Adipose tissue goes up. And what happens to muscle tissue?
On
It
the
shrinks.
economic issues,
But are the
sometimes,
two
certainly it can be hard to get
related?
people to change their diet.
Turns
But
out
what
that
we
adipose
did
tissue makes
is
inflammatory
we went
cytokines,
to the
interleukin
literature,
6, TNF alpha, and
the
those cytokines
USDA
contribute to
Gallup polls, Economic
sarcopenia.
Forum all say the
That's
average
why muscle
American
tissue gets
spends
marbled
about $250
with
a month,
aging.
family
So the
of
more
four,
muscle tissue you
somewhere
have, the
around
less fat tissue you're going to have.
$1,000
Yeah,
on,
you knew that,
on their
but here
groceries.
is
And we
the scenario.
do have references on these.
Here's the muscle.
We will, that support
It's
this.
inhibiting
We'll
the
give
fat
you
with
these,
interleukin 15.
This slide
Fat,
deck
on the
in
other hand,
it'll,
when it's excessive, is
we'll put
inhibiting
these in your
the
course
muscle. So the
materials
two
by
are at war
tomorrow.
with each other. You want more
And-
muscle.
and this is
When you have
just,
more muscle,
data
you're going to
on,
make more of that interleukin
differential
15, and that's going to
men and
activate
women
NK cells. So
and how
if you
old
have a
they are.
patient with
There's a
low
lot of
NK,
data that you can
especially
find
if
in,
they're overweight
in the
or getting
USDA,
older,
for
you're going to
instance, if you
wonder
go
about
searching for it.
sarcopenia. We need good
So
markers for
how do
sarcopenia,
these- how
and we don't
do,
really have them.
our
So
food
maybe
plans,
this
how do
one
the
would be a
IFM
a
food
good
plans,
surrogate.
stack up? What do they cost? And
Let's
so
talk
we
about
did
ANA,
some
kind of
significant,
everybody's favorite
review of
autoimmune
that.
test.
We went to
This should be
an
another
online
test that
Kroger's,
you
which is
order
a-
almost
a
without
store in the
thinking
Pacific
for
Northwest,
a
and
wide
their
range of
online,
inflammatory complaints,
food costs and,
fatigue,
and
low-grade
we looked that up, and we
fevers,
looked that up for
arthritis,
all of
weird
our,
rashes.
all of these food plans.
Don't question it.
And
Just
you can
get an
see
ANA.
the
The
elimination
ANA
diet on
can
the
go
top
up years
and the new food
before
plan on the
an
bottom.
autoimmune
Elimination
disease
diet is
has
very,
declared itself.
comparable to,
Okay? What does it
at-
mean when
at
the ANA
standard
is up? It
250,
means there's a
little bit
loss of
more,
immune
and the new
tolerance.
food plan a little bit more than
When you
that.
have a lot of
These
oxidative
were,
stress, it damages the
not-
nucleus.
we did
You
both
damage the
organic and
nucleus, now you're making a
non-organic.
freak
Organic is
molecule
certainly a little
that
bit
the immune
more,
system goes
but,
after. You make
I think the bottom
anti-nuclear
line here is the
antibodies.
cost to implement any
SLE
of
is a
these food
specific
plans
scenario where
is
there's
comparable
increased
to the average
apoptosis,
American,
right? You get a lot of
grocery
debris, a
bill,
lot of fragments of
as
DNA in
reported
the
as I
bloodstream,
showed
and
you.
that's what's
So,
stimulating the ANA.
now, clearly,
You know,
this
we're
doesn't
just taught
answer
to
the
order
question
in
of
medical school, not
access and food
why.
deserts,
But you
which
can't
is
help but ask,
certainly an
well,
important
why
issue,
is the
and we'll
person
talk about
making
that a little bit
antibodies
tomorrow,
against their
but
nuclear
that's a
material?
different question.
Something
So,
is either
really
releasing
the
more of that
take-home
nuclear
message I
material
hope you
or something
take
is damaging
the cost
that
to
nuclear
utilize
material.
these kinds of food plans is
Now,
reasonable and
a
realistic.
lot of people can have an elevated ANA, that's 1 to
and,
160,
just a
and
little
not necessarily
more
have an
data that I
autoimmune
won't
disease.
bore you with.
However,
So
that doesn't mean
I'll
I
end
ignore
on
it.
that,
I'm
somewhat
not
on
going to
that
say,
note.
hey, that's a
What
healthy
I
thing.
will say
It suggests
for,
to me that there is a
today,
loss of
there
tolerance.
is, there are
Something
brain
is
dates
going
that are gonna
on,
happen
and
in
I'm going to
just a
track
couple of
this person
minutes. If you
closely
wanna
over
participate in
time.
that,
I'm going to
get on
put
that
them on a good
platform. There are brain
anti-inflammatory
dates
program
tomorrow
and a
morning.
good
You can
gut program.
put
But
out
I'm not just going to do that one
a
time and
brain
then
date
forget
yourself
about
or
it.
see what's on
I'm
there,
going to
and if
track
you
them.
can sign up, I encourage you to do
A
that.
lot of people,
At
again, can
6:15
have it
Pacific
and
time,
be
which
considered
is,
to be normal.
45 minutes before
So
the actual
I
program
wouldn't accept that
starts.
right off the bat.
We're going to have
Now, if you do see
IFMCP
elevated titer 1 to
practitioner
320,
team
that's
gonna
when you want to get
present the
anti
path,
double-stranded
to the
DNA,
IFM certification
measure
program,
other acute
followed
phase
by,
reactants if you haven't
some
already done
Q&A.
it,
So if you're
measure
interested in
complement
that,
if you haven't
we
already done
encourage
it.
you
So
to come at that
ANA,
time.
nice,
If
handy
you don't wanna
little
wake up
test,
that early, or
very, very
you're
sensitive
it's in
for
the middle
initial
of the day and you don't
assessment
wanna
of
attend
lupus,
it,
which
that is
I should
obviously
point out is
fine.
the
We'll see
great
you
masquerader.
at,
A lot of different
7
conditions,
a.m. Pacific.
a lot of different weird
and,
symptoms,
we wish
swallowing
you,
disorders,
a good
skin
evening,
rashes,
morning, or
all kinds of
afternoon,
things like
and
that
we'll
can
see you
show
in a
up
few hours.
as can be a manifestation of lupus. Last but not least, anticitrullinated protein antibody, relatively new kid on the block, very useful for arthritis. What's going on here? With any kind of inflammation, for example, cigarette smoking, which is the #1 risk factor, #1 environmental risk factor for rheumatoid arthritis. What happens in the lungs in the smokers is you have activation of an enzyme called the PAD. That PAD enzyme substitutes arginine in native proteins for citrulline. Now, there's nothing inflammatory about citrulline or bad about it, but when you put citrulline into proteins that are lining the cells of the lung, the immune system doesn't recognize them. Something weird is going on. So you start making antibodies against a whole range of proteins, a wide range of proteins. We say that the anti-CCP is 98% specific for RA. It's really the laboratory standard for diagnosis and prognosis. But I want to tell you, there are other conditions like multiple sclerosis where the same antibody can go off. The deal is that the anti-CCP can go up years before clinical manifestations of RA. So do this first, and if this is negative, then do the cytokine panel second. Okay, a lot of information over this last hour plus. What have I told you? Acute phase reactants, simple, safe, cheap, easy to do. You should be doing them on a pretty regular basis on anybody with inflammatory symptoms. Complement levels, something to consider with a person who might look like they've got lupus, kidney disease, skin rashes, etc., and occasionally complement split product. Serum cytokines, a tertiary test that you can do when you're scratching your head and not sure where to go next. Sometimes in patients with multiple sclerosis, you want to get an IL-17. Otherwise, get the whole panel. NK activity for people with chronic fatigue, with cancer, herpes, or other recurrent infections. ANA for a range of autoimmune diseases, and anti-CCP as a predictive marker for rheumatoid arthritis. So that's what I have to say for now. We are now going to go over to a Q&A.
Well, thank you, Bob. That was wonderful. So it's nice to see you again. Let's dive in. So we're just going to have you and I are going to do a little interactive Q&A and case studies, and then we'll go to the panel Q&A.
Always enjoy interacting with you, Dan.
That's excellent. So I want to go. There we go. So let's do a poll. And you talked a lot about acute phase proteins. I thought you did a wonderful job. I'm curious as to what are the acute phase proteins that you all are currently using in your practice. Hopefully this, we want to see what you're using. Hopefully this will get you to use some of these a little bit more, particularly HSCRP or CRP, ESR, which Bob really talked about both at some significant, to some significant degree. So it seems like almost all of you are using CRP. Many of you are using ESR. That's wonderful. Not so many using fibrinogen. That's something that obviously Bob mentioned again.
Yeah, as part of usually part of a cardiovascular risk panel or somebody with recurrent clots.
Yes.
Serum amyloid A, if you can find a lab that offers it, will you please call me immediately? I mean, I do know one lab that includes it as part of a panel, but I would love to check it more often because I think it's distinct from CRP.
So let's go to a couple of questions about where you get some of these. So what laboratories perform that cytokine panel or cytokine panels that you mentioned? And obviously, which do you use?
Well, the main lab I use is ARUP, which is in Salt Lake City. They're a reference lab. So you can't really, you can't send them samples directly, but Quest, LabCorp, and Mayo Clinic all use them as their follow-up. So it's interesting, you don't necessarily know that. So if you order a cytokine panel, I think it's called the cytokine panel 13. If you order from Quest, Mayo, LabCorp, they'll send it to ARUP, right? So you know, ARUP is kind of in the background. The other lab that does that, that's a functional medicine lab, is Diagnostic Solutions, and they have a panel called CytoDX. Which I've been eager to try. They came out with it not long before the pandemic, and I never got a chance to try them out, but they do offer the same kind of testing.
How about this NRF2 and IFN alpha? Are those commercially available?
No.
Okay.
No, NRF2, you know, it's a more of a transient phenomenon, so it's mostly done in a research facility. It's like measuring NF-kappa B. You can't really get a test for it. And any lab that says they're measuring NF-kappa B, I would be suspicious of it. So, you know, I know labs that do that research. I know that Johns Hopkins does a lot of research on NRF2, but I don't know of a commercial assay for that. And also interferon alpha. And I'm really curious about why that question came up. Maybe in, you know, in context of COVID, perhaps.
Yeah, so you can just look at them kind of indirectly, is what you're saying. There's no.
Yeah, indirectly. I mean, you can measure interferon gamma pretty easily, but I'm not I haven't seen interferon alpha on any of the cytokine panels that I get.
Okay. Let's move to a case. So here's a 27-year-old female, presents with early morning stiffness, worse over the past few months. She's got swollen knees, but she has been associating this with a more active lifestyle. She has a normal inflammatory biomarkers, CRP and ESR, and she is negative for rheumatoid factor and ANA. She also tests negative for lupus. She does note a family history of osteoarthritis and RA and ankylosing spondylitis. So the questions for you, Bob, again, a simple kind of case vignette. How would you proceed? What else would you like to know?
So in some ways, this is a little bit more complicated than the patient we talked about this morning. This morning, we talked about somebody who's got swollen joints. You can see them, so there's no question she's got inflammatory polyarthritis. Now, this case is really similar to a woman I'm working with right now, where we're kind of scratching our heads and saying, you're having some joint pain, some morning stiffness, is this autoimmune or not? Do you have a loss of tolerance? I probably will interact with her a little bit and say, well, how much of a workup do you want me to do? Do you want to just see if we can treat this with some basic supplements like, the fish oil, curcumin, boswellia? I would certainly not treat her with NSAIDs because that could perpetuate the problem. But I want to get a feel for the patient, like, do you want me to work this up? If she did, then I might do a cytokine panel on her. This is kind of the patient we're talking about that potentially has very early loss of tolerance. And so I might do a cytokine panel. And I did that with a similar patient, and it was negative. Well, it was interesting because that other patient had seen a rheumatologist, and the rheumatologist says, well, I don't know what you have, but it's probably going to be RA someday, so we might as well just give you methotrexate or a really strong anti-inflammatory, a potent pharmaceutical. And I don't want to say I felt strongly against that, but it's not the way I would go. Mm-hmm. I'd like to see some evidence that this is clearly an immune-mediated problem, and that's really the main question here. And a cytokine test is probably the best way to go, in my opinion, because you've already done all the other markers that I've talked about. You might want to do complement levels. I don't know if they would add a lot. You could also consider doing some kind of food allergy testing. There's one, particular food inflammatory test that I sometimes do. I know, that's Kara's purview, and so we could debate about the pros and cons of that for a long time. But that's just well, what else could we do? You could certainly try a fast, oligoenergenic fast and see. This is actually a tougher patient than the one we talked about this morning.
Okay. So, this question here that I think you answered this. The question is, borderline elevated ANA. You talked about ANA. Anything else that you think about? I think you kind of went over this, how you would approach a borderline elevated ANA. Anything else to add, Bob?
Well, I think, you make the point to say, besides gut health and diet, I mean, that's where I'm going to go. It's gut health, because what's the most obvious source of something that could be causing a loss of tolerance? I might consider doing a DNA analysis of stool, right? A gut microbiome test, just to see if there's any weird bacteria that could potentially be inflammatory triggers. That's probably what I would do. And then I would treat with glutamine and probiotics and N-acetylcysteine. Why do I mention that? Because N-acetylcysteine, which raises glutathione, has been shown to be helpful in lupus. So I use that, and I also use cordyceps a lot because of more of the research on cordyceps and lupus nephritis, but by implication, it having immunomodulatory effects. And this is a fairly common scenario. So, you know, you got an ANA, you ignore it. A mainstream rheumatologist would probably say, well, it's not declared itself. Let's just wait and see. But I think it indicates that something is going on. So I'm going to engage in some sleuthing.
You're stealing your own thunder about talking about NAC. You'll talk about that tomorrow.
I'm trying to whet people's appetite.
Good. So let's go to another poll. And that is hopefully you'll have some good ideas after Dr. Roundtree talked about triggers of HSCRP. What are triggers? Obesity, it's the common suspects that Bob talked about. Smoking certainly comes up, that obviously, but obviously, again, obesity, trauma, hyperlipidemia, all good answers. Dysbiosis, I think, can. Any kind of occult infection.
Yep.
Yep, all of these things. I think.
And I've seen it in people that ended up having like a deep infection in a tooth. You know, I'm not a dentist, so I don't like do any kind of dental assessment on people. But I've had people with high HSCRP that I sent to the dentist who said, yeah, sure enough, you've got infection, and even had to put them on antibiotics.
Yep. Well, there's gingivitis also comes up. It's coming up.
Disease and as well.
So let's talk about another case. Patient presents with a markedly elevated HSCRP, but does not present with any other symptoms of inflammation and appears to be otherwise healthy on a screening exam. So how would you proceed, Bob? What do you correlate this with?
Yeah, I mean, the first thing I want to make sure is that it's real. And some people, I might just repeat it in a week. If they're that healthy, if they're not overweight and their gums look fine, I'm going to certainly do a lymph node exam. If it's an in-person visit, a little harder to do with telehealth. I do sometimes have people in teleconferences, holding up their arms and showing me their clavicles and that sort of thing. But if they really, really look healthy, the first thing I do is question the test. So I'm not going to spend $1,000 doing tests until I've confirmed that it's up. And I've occasionally seen this scenario where it's up and then a week later it comes back down, and it makes you think, maybe they went for a run the day before or something that didn't really register. I have had that happen. I've had people go out and do a major workout, and that was enough to raise it for 24 hours. So sometimes these innocuous things can do it. So again, I want to make sure I've done my due diligence, and then other labs besides just repeating it, as I would get a SED rate, if I mentioned, a SED rate and a CBC. I'd probably just do that.
Okay.
Not too elaborate until I've got a better sense of the person's lifestyle.
Let's go to one more question before we bring in our other esteemed colleagues. So, Bob, you mentioned both CRP and ESR, SED rate. If you order them together, how do you interpret if one is elevated and the other is not? How do you, if there's discordance?
Yeah, well, that's the whole reason for getting them both together. If you order a CRP and it's negative, then you're going to have to come back and order a SED rate. If you order a SED rate and it's negative, you're going to have to get a CRP. So do them both together. If they're both elevated, then that's fine. That tells you, yeah, there's an inflammatory disorder going on. Again, CRP is an indicator of elevated interleukin-6. So it's a specific kind of inflammation. But, further than that, the best I can say is that every person's an individual. Every person's immune system is going to react in a slightly different way. So when I'm doing both these tests together, I'm just looking for I want to know if it's raining outside, right? I'm looking for some indication that there's weather coming in.
Well, if you see an elevated HSCRP and a normal SED rate, does that
I'm not perturbed by that. No, if you're asking, does
it's
that
more
bother me?
sensitive. Go ahead.
Yeah, the CRP is a lot more sensitive. I would just say maybe you picked it up earlier. So there's a long list of reasons why you would get discordance.
Okay. I think we're going to skip this polling question, and we're going to, in the interest of time and getting in Dr. Fitzgerald and Dr. Messier, we're going to go to the overall Q&A with our attendees. And so a few comments before we get started. So first, there are many questions. That's great. There are some questions that I think will be answered later in the program in another presentation. So we'll try not to spend time on those now. So for instance, the question on probiotics and SIBO and inflammation, I think that will be perhaps answered tomorrow in a presentation. If not, we'll come back to it. There's also a number of questions that we have preemptively answered. We have a frequently asked questions, an FAP in your course material where we answer a number of questions that have come up commonly that we've referenced that. So I won't answer those questions. We'll try to put on these that, well, that's in the FAP, and I encourage you to look at that sometime tonight. And third, we, of course, as I say, have a lot of questions, and we will answer some of them here. We will certainly answer some of them tomorrow, and the next day we'll answer them in the small Zoom chats that I mentioned that we'll do tomorrow and the next day. And then also we have these two Q&As that we're going to take some of the leftover questions and answer those in webinars that we're going to do later, and those will come out in a couple of weeks. So we're going to answer a lot of questions. We're not going to answer all the questions here. So with that, let's get to a couple of these questions. And I think, Bob, I just want to make sure that we answered one of them. Is there a way to reliably measure clinically relevant elevations in NF-kappa B in serum?
No.
Okay.
Not that I know of.
No.
I mean, you can do it in a university setting, but there's no transport involved in that blood, right? You collect it on site, and there are obviously there are assays, but not that the likes of you and I can get access to. You agree, Helen?
Absolutely, Bob. I mean, remember, it's an intracellular transcription factor, right? So it's either attached to I-kappa B or it's binding to the DNA. So if you're going to even measure it, you'd obviously have to break open the cells. What cells are you measuring in, the leukocytes or others? It's just, it's not something that any of the commercial labs do, but so I completely agree with that.
It's the same as with NRF too.
Exactly.
Yep.
Yeah. Yeah, I don't really know of a good transcription factor, any of the transcription factors in terms of any assay that's available to measure them. We have to just measure the downstream effects of them. So, you know that NF-kappa B turns on the many inflammatory genes. We can measure those gene products, but we can't measure the upstream transcription factors.
Let's turn to a question on I'm going to turn to Kara on this one on omega-6. So the question is, what are your thoughts on the common claim that industrial processed seed oils and omega-6 fats, and especially linoleic acid, are a major driver of inflammation and chronic disease?
I don't know that I would say that they're a major driver. I mean, I think that, Bill Harris his group published something, I think last year, saying we shouldn't even be concerned about our omega-6 levels. I don't agree with that. So I've got a handful of thoughts. One, you need to get really clean source oil. It's got to be fresh. You don't want it to be rancid. It's polyunsaturated, so those double bonds are vulnerable. So it's got to be appropriate oil, high quality, ideally organic or very clean and fresh. And, you know, you keep it in the refrigerator. You know, just as I said, looking at Chilton's work, GLA will convert to arachidonic acid, as will linoleic acid. So it may, while it may not be the main driver of inflammation, it's certainly one of them when it's in imbalance. And there's only so much lipid membrane to a given cell. So you want to make sure that it's as packed with, well, it needs to be packed with a sufficient amount of omega-3 fatty acids. So when, you know, phospholipase A2 is activated and it cleaves the phospholipid, that you're going to get EPA or DHA versus arachidonic acid. So while I don't know that I would put the full weight of implication on linoleic as a driver of pro-inflammation, it's one of them, and we need to think about it, you know, with care.
Can I just add to that real quick? I think what you said, the clean source oil, I think one of the reasons omega-6s have such a bad rap is that they're all heated. You know, when you look at the fast food industry, they're used for deep frying. I used to use lard. Now we use the omega-6 vegetable oils for deep frying, and that produces a lot of really toxic byproducts. Yeah,
that's right.
Yeah.
So I think it's those oxidative end products that are, you know, as problematic or more so. Yeah, good point.
I think the interesting story about arachidonic acid is how it's actually a precursor to anti-inflammatory chemicals. That to me is the big discovery, you know, in the last 10 years or so, is that we used to vilify arachidonic acid. That's the bad guy, but arachidonic acid is made into anandamide, right? And
it sure is. Well, and that's right. And lipoxin. Yeah, that's right. That's right. The whole lipoxin family. Yeah, we can't resolve inflammation without lipoxins.
Right.
But we don't need the same quantity, and B, if we're taking non-steroidal anti-inflammatories, we're going to inhibit, you know, that conversion. So I think most of us have plenty of arachidonic acid to make anandamide, to make lipoxins, but we actually have excess amounts. So we've got enough substrate to make those anti-inflammatory derivative molecules, but we inhibit arachidonic acid from converting. I mean, I think there are other variables that are turning off our access to those molecules.
So let me go to another question. We're going to come back to essential fatty acids in a couple of minutes, I think. But this question that got a lot of upvotes: if caffeine decreases inflammasome activity, why are we recommending cutting it out like in the elimination diet? So let me speak to that briefly. We recommend cutting out caffeine in the elimination diet because caffeine in susceptible individuals can have a lot of effects on blood sugar dysregulation. I personally have a love affair with caffeine. I drink a lot of coffee. I think my SNPs are raring to go with caffeine. We know that caffeine and coffee specifically has a lot of positive epidemiological studies. It's not that coffee or caffeine are evil, it's to take them out to see how that affects a person over 4 weeks. So I think, unless any of you want to add to that.
Just to reinforce that point, because I was talking about the elimination diet as well. The elimination diet is not a forever diet. A lot of the point of the elimination diet is to identify which foods, which factors are actually a problem for that individual. It's not meant to be stay on this long term. I think that's really, and the same with caffeine. You're right. Some people, it will increase their stress hormones, and stress hormones we know increase blood sugar, and that's an issue for some people. I'm not as lucky with you as in the SNP stand.
Caffeine is another one of those things that was vilified for, like arachidonic acid, like, oh, if you want to clean up your act, you got to get rid of that caffeine. But, now we found it's a more nuanced nuanced argument. That's how I would put it. It's like arachidonic acid, right? It's you know, for some people, caffeine is probably